I realize today's topic is a little bit unusual for Grand Rounds. I'm indulging my interest in history in covering this. It's something that I ran across a few months ago when I was reading about the International Medical Tribunal that followed World War II, and they mentioned the Nuremberg medical trials, and there was mention made of the Nuremberg Code, which kind of piqued my interest. So as I started reading it, I thought that it would actually be a good topic for Grand Rounds because it deals with informed consent. We're going to look at that today. Basically, I'm going to give this talk in three parts. The first part is going to have to do with informed consent as we understand it today. Then we're going to go back and look at the history of informed consent as it was present in the Second and Third Reich from about 1891 until through World War II. And then look at some conclusions that we can draw from that. We're going to look at the Nuremberg medical trial briefly and mention the Nuremberg Medical Code. Hopefully we'll have a better understanding of how informed consent came about and see the limitations that we have. And the topic being what it is, there are no conflicts of interest. You know, we all talk about informed consent a lot in medical school from the beginning of our training, and it seems to be well established and historical, but if you look at the review of history, this is a misconception. If you go back and look at Egyptian, Greek, and Roman codes, there's no specific mention made of informed consent. There's mention made of beneficence, non-maleficence, patients' rights and autonomy, but not informed consent itself. Now, if you go back and look at the Oath of Hippocrates, you can understand that because in the time of Hippocrates, the doctor-patient relationship was much more paternal than it is today. And it was just understood that if the patient went to the doctor, they expected to be helped and they would consent for treatment. We've moved away from that and it's changed our understanding of informed consent somewhat. So, since we don't have anything in the Oath of Hippocrates or more other traditional oaths, what do we have? Well, first of all, a definition of consent itself is permission for something to happen or to do something. Now, that's a fairly crude explanation or definition of informed consent as we know it in medicine. So what do the medical dictionaries say? Let's look at Dorland's Illustrated Medical Dictionary. There is no definition of informed consent in Dorland's. Okay? And nothing. And so Stedman's, there's no definition. So what do? Well, first of all, we can look at our professional societies. The AMA says consent is in the Hippocratic Oath is implied, and it's based on the things we've talked about. Beneficence, non-maleficence, spells out to a limited degree what we can do in emergent situations, and that's basically condensed quite a bit. The ACP, there in some legal jurisdictions, if you treat a patient without their consent is considered battery, assault and battery. So we get into legalities here. The ACP says that there are two types of consent. One is expressed, and this mainly occurs in the inpatient setting where the patient actually signs a consent form for treatment. And when a patient comes into the hospital and consents for treatment, they're allowing us to do the basic diagnostic and therapeutic tests that allow us to take care of their problem. But we still ask them to sign a more definite consent for a major procedure or something that's more risky. Implied consent is what occurs most often in the outpatient setting, where by virtue of the fact the patient comes into the doctor's office, sits down in the chair in the exam room, consent is complied. Now, of course, if you're in clinic, you know we still get written consent for certain procedures, something as simple as joint injection, but by and large, if the patient comes to you in the office, they're consenting for treatment. And the ACP says that the physician must provide enough information to the patient for an informed judgment to proceed. It has to include the patient's understanding. It has to be balanced, but it also has to contain the physician's recommendation. The evolution from consent to informed consent came about as a result of four factors. One is just a general change in attitude toward rights and duties. Patients' autonomy is stressed more now than it ever has been. There's more of a spirit of scrutinizing rules governing human interaction. In other words, we're more critical of looking at things than we used to be. The other thing that's changed is medicine's developed, treatment has gotten more sophisticated and complicated. We do more things to people and they're more complicated today than they ever have been. And the other thing that's stepped in is a breakdown of the caring one-on-one relationships in medical care because we moved to team approaches. You know, think about our rounds now when you're sitting in your team room. How many people are in there? Not just the doctors and the house staff and the medical students. You've got caseworkers and social workers and PharmDs, and so the team room has become a very crowded place, and so is the exam room. You know, patients will bring in things like, if you'll fill this out, I can get disability, or I need something for my wheelchair. So all of those things constitute intrusion into the doctor-patient relationship in the exam room, and parallel to that is a change in the way that we do informed consent. It's changed. These are basically the components of informed consent, and this was from an article last week in the New England Journal. It's in my references. It's actually a pretty good overview. Components are disclosure. That's pretty much what you tell the patient, and it differs between patient care, which is helping the patient, and research, which is generating knowledge, and we're going to talk about that more when we get to the Nuremberg Code. The second part of informed consent is comprehension. It's not just what the patient comprehends, but it's what the doctor comprehends the patient comprehends. Okay, you have to determine how well the patient understands what you're telling them before you can really get consent. I just saw a patient in the clinic with a house staff with schizophrenic, an uncontrolled schizophrenic. So how much does this patient comprehend, and can you really get informed consent from this patient? So you have to understand what the patient understands before you can proceed. Then the patient makes a voluntary choice and they authorize you to do whatever it is you want to do. Now, some other problems, and I've touched on this. One of the problems for us today in clinical practice and research is that clinical information is becoming overwhelming. There's more of it. And the patient's required to digest. And the other thing, not just here, but in private practice, is the increase in complexity of technology is not being paralleled by the patient's increase in science and health literacy. Okay? And that's a particular problem in our patient population, but it's a problem in private practice as well. That the patient, we've exceeded the patient's ability to grasp the information that we're giving them, and it makes our job harder. The other thing is we're getting older, and we're going to see a flood of aging baby boomers in the next few generations, in the next few years. And we're all going to get a little bit dotty, okay? We're not going to be quite as mentally sharp as we were before. The number of patients over the age of 65 will double. The number over 85 will more than double. And by 2050, the number of patients with Alzheimer's disease will double. And the other thing is, in clinical practice, we really don't have a very good method of evaluating for mild cognitive impairments. The MMSE is just a basic crude screening tool. We have to get it through the artwork of taking a social history and asking the patient about their functional status. And even then, I think oftentimes we underdiagnose cognitive impairments. And as this gets to be more and more of a problem as patients get older, it's going to get to be harder and harder to know if we're really getting informed consent on our patients. I'm going to throw out two models here of the different types of informed consent. I just thought this was interesting, and if you listen to this, you'll see the interaction with all different kinds of patients. The bottom line is no one model fits all. And these were just two psychoanalytical model, and the first one is basically activity-passivity. Basically what the physician does is does something to the patient, and the patient's unable to respond. And this is in a comatose patient. And no, it does not refer to our clinic patients. Almost, but not quite. Most of our clinic patients follow the second, which is guidance cooperation. The doctor tells the patient what to do, the patient cooperates. I tell the house staff in the clinic, some patients, I can tell them, look, I've got a loaded revolver here. I'm going to put the muzzle to your temple and pull the trigger and blow your brains out, and the patient will say, whatever you want to do, doctor. And there are a lot of patients, both in private practice and here, that are just that passive. I think most of us would really like to operate by the mutual cooperation model. I think it's the most satisfying to use because basically The patient helps the patient to help themselves. The patient's role is to participate in decision-making. It's a partnership. And that's the one that we would most like to use. We inform the patient of their choices, tell them the risks, the benefits, discuss it, answer questions, and unfortunately it just doesn't happen that often. And it probably happens less often than we think. The second one were described by Emanuel and Emanuel, and they're basically looking for what should be the ideal relationship. And they see it as a conflict between patient autonomy and health, but they also see a conflict between our values and the patient values. I'll give you an example. In our African American patients, they have a very traditional, unusual role about the patients as healers. They see the patients as a tool used by God, but they also think that whatever happens is God's will. And that's the value that they bring into it. So when you see a patient with these values and say, you have a blood sugar of 600, you need to do something about it, they'll say, well, whatever God wants to do is going to happen. Okay, and that's a conflict between the values that we hold and the values that they hold. But anyway, the three that they see are, first of all, paternalistic or guided submissive, which is very similar to the guidance cooperation, or pardon me, the passivity model. The physician acts as the patient guardian. And particularly older patients, they want us to be their guardian. They want us to take care of them. They want us to make the decisions because it's too complicated for them. And so oftentimes, the interaction between the doctor and the patient falls into this role. The second one is the informative role. And you're going to see, we see more and more of this today because there's so much information out there. A patient comes in and says, I saw this on the internet, or I read this in a magazine. And basically they're using you as kind of an organic website. Or as I like to say, the patient puts in their $25 coat, they come up to the vending machine, put in their copay, pull a lever, and out pops the treatment that they want. One of my partners said that basically physicians have become a commodity like a box of camera film. That's the kind of interaction that you're getting with the informative role. And then the third is the interpretive role, which means you're interpreting and elucidating the patient's values and providing information and implementing treatment decisions. Again, you're accounting for the patient's values before you decide how you're going to proceed. Then the last is the deliberative role, where the physician's role is articulating, persuading the patients the most admirable values. In other words, you're trying to impose your values upon them. And whether we like it or not, all of these roles are operative at one point or another in different patients. You can't take an anal retentive engineer and be paternal with it. He's going to want more of the informative role. You can't take the informative role with a patient whose literacy level is second grade. So whether we realize it or not, if we've been in practice long enough, we use all of these models to get consent from our patients. Now, have we abandoned paternalism? There's a lot of push. There's an emphasis, I think, an overemphasis today for patient autonomy. Well, first of all, I don't think patients ever completely give up paternalism. I don't think they're completely autonomous because, quite frankly, we have learning and information and expertise that they don't have. And as I said, I think there is an implicit consent for treatment when the patient comes to the clinic or the examiner to be treated. I think patients who take the informative role for informed consent would probably push back on that. But we have to remember that even if we're treating another physician, the patient can't treat themselves. So I don't think paternalism is dead. The patient meeting an examiner is the acknowledgement on their part the patient hopefully has training, information, and experience that's needed. Yet paternalism today is defined as the power and authority one's person or institution exercises over another to confer benefits or prevent harm. So there's part of autonomy in what we do as well. So basically, where did all this come from and where did it begin? And probably you're asking yourself, what the heck did the Nazis have to do with it? And so we're going to go into that. And as we saw in a grand rounds a few weeks ago, we got there in steps. First of all, in 1859, Darwin published The Origin of the Species. And basically the idea of natural selection and survival of the fittest was applied to the animal kingdom and the plant kingdom in general. The next step, though, was applying this to the human race. And that next step was taken by an Englishman in 1883, Francis Galton, who founded the eugenics movement. They believed that selective breeding could improve man, and that if we could breed genetically superior people, mankind would improve over time. Then, in 1894, Albert Plotz in Germany coined the term racial hygiene. It went beyond this. It said not only can we selectively breed human beings to improve mankind, but we should also prevent breeding of genetically inferior species or types to prevent degeneration of the human race. Now, that all sounds kind of wacky today, but it was very, very influential in the late 19th century. As a matter of fact, in 1907, the International Society for Racial Hygiene was instituted. The United States got in on it. We had our own American Eugenics Society. In the 1920s, German eugenics research was supported by the Rockefeller Foundation. So it caught on. As a matter of fact, you might be surprised to know that in the 1920s and 30s, Winston Churchill believed in eugenics. It was only after the onset of World War II and the revelation of what the Nazis did that he became repelled by it. Now, before we write this off to quackery, we need to understand something about German medicine in the early 20th century. It was not out in left field. It wasn't voodoo dolls and potions and mojos. German medicine was one of the leading medical education communities in the world. They were leaders in epidemiology, preventative medicine, public health, health screening, occupational medicine, workers' comp. And as we're going to see, they had some very well written informed consent codes at the time. Many of these programs actually go back to the time of, in the late 19th century, of that famous lefty Otto von Bismarck. Von Bismarck has a reputation of being a right-wing extremist, but his domestic policy was actually quite liberal. He instituted all of these public health things that we're talking about. As a matter of fact, at this time, Germany had universal health coverage. So, and it was instituted by Bismarck himself, and it was well established by the time the Nazis came along. So, German medicine wasn't out in left field at the time. It was one of the leading countries in the nation. The first code that we come across in Germany is in 1891. A physician was actually carrying out his own little research experiment. He infected, I believe, 4 prostitutes with syphilis intentionally to study its effect and design treatment. He had a defense that was the women were prostitutes, they were going to get syphilis anyway, so what's the big deal? It was an occupational hazard, and therefore he was performing a public service to prostitutes and by extension society in general. And again, this is utilitarianism or Hegelian ethics. This is the code that came out of it. I've condensed this greatly. It's pretty wordy. So you can see that's not a bad code, is it? It includes a lot of the things that we would consider today to be part of informed consent. Then there was a second occurrence, 1931. There were some researchers in Lübeck who were doing research into a vaccine for tuberculosis. 75, they were testing it on children, 75 died. And this code is extremely wordy. I didn't try to type it all out because it would take me all day to type it. And it was, since it was legal, it was incondensable, so, but it is in one of the references. But it actually predated or looked forward to the Nuremberg Code in great detail. So you can see in the early part of the 20th century, there were 2 very good codes on the books as law in Nazi Germany, or in Germany before the Nazis came to power. So how did we get there from here to the concentration camps? Well, first of all, you have to look at German culture and society between the world wars. First of all, Germany was assessed the guilt clause of the Versailles Treaty, It was a very unpopular thing in Germany. They didn't like being blamed for the war. They were saddled with severe reparation payments. And when Germany defaulted on the payments, in one instance, the French actually came in and took over the Ruhr, which was the German industrial heartland. After the war, after the Kaiser abdicated, there was a republic form of government, the Weimar Republic, which was very unpopular and also very unstable. And one of the reasons it was unstable, if you go down a couple of lines there, the polarization of the right and the left with a weak center made it impossible to govern without a coalition, so they were having government turnover every few months. German currency was worthless. A dozen eggs that would cost 2 million Reichsmarks in the morning would cost 6 million Reichsmarks by that afternoon. It would take a wheelbarrow full of Reichsmarks to buy a pair of shoes. The currency was worthless. About the time they were getting over that, they had the stock market crash in 1929. And then that old bogey, the fear of the spread of communism, was always in the background. A lot of people voted for Hitler because they feared the communists. And then also there was nationalism. People longed for going back to the good old days when Bismarck was the chancellor and we had a stable government. So all of those things were part of German culture between the world wars. So how did medicine get wrapped up in all this? Well, first of all, German physicians were German, and they were regrettably German first and physicians second. It's interesting that even before Hitler became chancellor, 6% of German physicians joined the Nazi Party. And German physicians were 7 times more likely to be a member of the SS. And this was before Hitler became chancellor on January 30th, 1933. In addition to that, most of these physicians trained in the 20s and early 30s. And they didn't like what they saw. They felt that medicine was becoming too technology-driven. It was too business-like and overly specialized. That doesn't sound familiar, does it? But they saw the same thing in the 1920s. But they also, believe it or not, doctors were unemployed. There was a lot of unemployment doctors at this time. They were looking for jobs, and Hitler promised them jobs. So that made the Nazi Party very desirable to them. Now, there was still blatant anti-Semitism, not just in Germany, but throughout Europe. And it was also present in other countries in Europe. In 1933, Hitler became chancellor, and things shifted into high gear. There were 3 laws that were passed early in his chancellorship that moved toward euthanasia and concentration camps. The first was the sterilization law in 1933. It mandated sterilization for those suffering from genetically determined diseases. And let me read you some examples. Let's see. Epilepsy was felt to be genetic. Huntington's chorea is. Congenital blindness and deafness, alcoholism. All these patients were candidates for mandatory sterilization under these laws. And step 2, 1935, the Nuremberg laws were more draconian. They excluded Jews from citizenship. Jewish doctors could only treat Jewish patients. Jewish dentists could only treat Jewish patients. Not only that, but there could be no contact between Aryans and non-Aryans. So as a result of the Nuremberg laws, the Jews also lost their citizenship and all rights that went with it. Step 3 was the euthanasia law, which was mentioned a few weeks ago, provided a mercy death for those felt to be an excessive burden on their families. It's interesting that the initial request for euthanasia was made by the father of a handicapped child. He actually wrote Hitler and said, "My child is an excessive burden, they'll never grow up to be normal, can we get them a mercy death?" And that actually instituted what became known as the T4 program in Germany. It's interesting too that when you read the journals of these physicians that actually were responsible for deciding who lived and who died in this situation, When you read their notes, it was just like another day at the office. I decided 200 cases today, and it was just detached. And yet they were sending hundreds of patients to their death. As a result of all of these activities, in 1939 to 41, there were 40,000 adults euthanized in Germany. And actually, 400,000 underwent mandatory sterilization under the first law. It was a very active program. It's not considered to be part of the Holocaust per se, but the techniques that were used in these laws, or as a result of these laws, were a precursor to the Holocaust. It's where they found poison gas, carbon monoxide poisoning. Many of the victims of the euthanasia law were dispatched by injecting phenol into their heart while they were conscious, or they were allowed to starve to death. Now, what kind of physicians would do this? They weren't quacks. A lot of the physicians involved with this would have been the leading physicians of their time. Karl Brandt was the chief of surgery in one of the most prestigious hospitals in Berlin. He was actually Hitler's surgeon. Removed a vocal cord polyp from his vocal cords during the war. There were others. Ferdinand Sauerbrock was a well-published and well-regarded surgeon. Gerhardt, Gutzeit, they were all not as famous or infamous as Mengele, who we all know about, but they all played a part in what went on in Germany in the 1930s and 40s. And the other thing that happened in the medical community, this is a German term, Gleichschaltung, which means marching in step. Physicians were coerced or chose to march in step with what the Nazis chose to do in Germany at this time. And again, it didn't include just old quacks and family docs, but many of it would be like Anthony Fauci in the United States today signing on to something like this. It was that remarkable. But what about the United States? How many of you have heard of the Tuskegee experiments? Anybody? Do you know when they ended? Anybody? 1969. Not that long ago. 25 years after the war. 1989 through 07, Indiana carried out mandatory vasectomies on 465 patients for no other reason than we didn't want them to reproduce. And the law was subsequently extended to mentally handicapped. It was upheld by the Supreme Court in 1927. And another mark on our collective conscience, in 1939, 5,000 African American physicians applied for membership in the AMA, and every one of them was turned down. Now, I'm not going to go into all the details about the Holocaust. There are some books that I would be happy to share with you if you want to read about that. Martin Gilbert and Lucy Davidovitz wrote some authoritative accounts of the Holocaust, but since most of you are eating lunch, we won't go into that. All right. The experiments were largely in Germany before the war were carried out, during the war were carried out on Jews, both German and non-German, and POWs, mostly Russian and Polish. Prisoners were exposed to things like extreme cold to see how well they could survive. They used different techniques to warm them up and see if they could survive. They were put in decompression chambers to see the effects of high altitude and observe through a glass to see what happened. They would give prisoners salt water to drink for days to see what the effect of drinking salt water on them would be. They infected prisoners with typhus and gangrene just to see the effects, but also to look for vaccines. And then there were other things like bone, muscle, and nerve grafting, and then there was a study of twins by the infamous Dr. Mengele. So after the war, the Nuremberg medical trial was an offshoot of the International Military Tribunal. It began in December 46, testimony ended in 47, July 47, and verdicts were rendered in August of 47. And 16 of the 23 defendants were found guilty and sentenced to prison, although many of the sentences were later commuted. The three charges were an extension or variant of what was used in the International Medical Tribunal. It's interesting that they felt like their best chance of conviction was the conspiracy charge. They felt that it's very hard for us to prove that this doctor killed this patient. And if you think about it, when you murder 6 million people, it's very hard to point to any one person that killed any particular patient. So they used a conspiracy charge, but also tried against war crimes and crimes against humanity. It's interesting that the defense was actually able to get the conspiracy charge thrown out before the trial, but they were still convicted. Now, the other thing that's interesting and critical to how the Nuremberg Code came out is they only prosecuted the doctors for crimes committed against non-Germans during the war. They did not take up the issue of the euthanasia or T4 program or crimes that Germans committed against Germans. And they felt like they lacked jurisdiction, although how someone could conclude that, I guess only a lawyer could. But I think the other part of it is that 1/3 of the commission was Russian. And if the Russians had had their way, they would have murdered them all. They would have sentenced them all to death and taken them out and shot them. So I think there was pushback between the British and the Americans and the Russians. The Russians would have been much more aggressive. But it has an impact upon the Nuremberg Code itself, because we'll see that the Nuremberg Code itself did not address issues that are related to doctor-patient relationships. It was more limited. There were 2 medical experts. The first is Dr. Alexander Ivy. After the war, it's interesting, he was caught up in a fraud case regarding a cancer chemotherapy drug. Ended his career in hiding. He wasn't convicted, but as a result, he kind of went into hiding. Leo Alexander was a neurologist, psychologist, practiced in Boston. It's interesting, too, in their testimony that they relied very heavily on the Hippocratic Oath. Again, it's a tradition that we all follow. Let me read you what Ivy said in testimony. I think it should be obvious that a state cannot follow a physician around in its daily administration to see that the moral responsibility inherent therein is properly carried out. This moral responsibility that controls or should control the conduct of a physician should be inculcated in the minds of physicians just as moral responsibility of other sorts, and those principles are clearly depicted or enunciated in the Oath of Hippocrates, with which every physician should be acquainted. According to my knowledge, it represents the golden rule of the medical profession. It states how one doctor would like to be treated by another in case he is ill, and in that way how a doctor should treat his patients or experimental subjects. He should treat them as though he were serving as a subject. He also referred to other ethics codes that dealt with doctor-patient relationships and research in his testimony, but it was largely centered around the Hippocratic Oath. Here's the defense arguments that were used. And again, they're very utilitarian. The German doctor said, well, these patients were going to die anyway. It's rather crass when you think about they were going to die because they were going to be killed by the Nazis. They volunteered. Since they volunteered, there was no crime committed. Patients volunteered for this. This is the best one. Doctors are not responsible for and have no knowledge of values. And the way they expressed this was, that's order, Befehl ist Befehl is German for orders are orders, which was the same excuse used by the German generals in the International Military Tribunal. I was just following orders. They said that all of the moral and ethical implications of what they were doing had already been worked out by government officials. I was just doing what I was told. Then they said they were acting for the greater good. The security and defense of the nation was at stake. And it was reasonable to sacrifice the lives of the few to benefit the many. Many of the experiments that were carried out in the camps were intended to help preserve and save the life of German soldiers. For example, the decompression testing were used to hopefully help treat German pilots. The cold water immersion, German pilots that were shot down in the North Sea, they were trying to save the lives of their soldiers. Time and time again, they referred to the danger to Germany posed by racially inferior minorities. They held to that even though they were on trial. And if you listen to their testimony and you go back and read what was written, particularly by Hitler at this time, They were described as vermin, bacillus. The Jewish community was considered an abscess on the body of Germany that had to be excised. So here's the Nuremberg Code summarized. And it's written in its entirety in one of the references that I'll give you at the end of the lecture. First of all, it said voluntary consent is essential. The experiment should yield results for the good of society. You can see them there. Here's the next 5. All looks pretty good, doesn't it? What it doesn't, but if you look at it, none of this really talks about what most of us do, which is the doctor-patient relationship in the exam room. And this is where the impact of not prosecuting for German crimes against Germany comes in. This was just had to do with the experiments that were carried out in the death camps. So the Nuremberg Code more specifically addresses principles that should guide us in our attempts to carry out therapeutic and non-therapeutic research. So even at its best, the Nuremberg Code really does not address informed consent as it relates in the exam room or the hospital bed. Here's what it will do. Well, first of all, it has several strengths. The voluntary consent is absolutely essential. It rejects that crass utilitarianism that the Germans used and putting forth by the defendant. It also places very heavy responsibility on the researcher to assess the risk before asking anybody to participate. Let me back up and say one thing. When I was talking about the 3 laws that were passed in the 1930s, it's also interesting about that time that Germany passed a law that forbid medical experimentation on animals. It was felt that it was cruel to experiment on animals, but yet they experimented on human beings. It's also interesting, too, during the war, the one nation, the one occupied country that fought back hardest against euthanasia was Holland, the Netherlands, or Holland. And it's interesting that now they're one of the leading countries that propose euthanasia. So they've come full circle. The Nuremberg Code has several shortcomings. First of all, it doesn't address the idea that the defendants did not need to consider the moral implications of their work. It also did not address whether the extreme demands of war justified the extreme measures justified by the state. Several years ago, probably 25 or 30 years ago, it was asked whether or not the scientific community at the time could use the raw data generated by the Nazis to do research today. And it was rejected on the fact that it would be carried out on the backs of people who were murdered by the Germans. And it was decided not to use that raw data. It's still out there. It's still in archives. It's actually come under criticism because it doesn't talk about patients who are unable to grasp the implications of what is about to happen. It asserts the willingness of the investigator to expose himself to risk. The other thing that's interesting, it allows the researcher to engage in research that's potentially hazardous as long as he himself is willing to be a subject. And as a matter of fact, Dr. Alexander, I believe, used himself as a test subject before the war in some of the experiments that he was carrying out. That's interesting. The greatest shortcoming of the code is that it's been ignored, or was ignored at the time. Now, since the Nuremberg Code has come out in 1947, we've had some other codes come out. First of all, the Helsinki Declaration in 1964 deals with voluntary consent. It was revised in 1975. The code was rewritten in 1983 and revised again in 1989. And it builds on the Nuremberg Code. But if you look at it, as I said, there were 2 perfectly good codes regarding informed consent in Germany from 1891 and 1907. So what happened? It happened because it was ignored. The codes were ignored. So there again, that's what the Nuremberg Code does, and that's what it doesn't do. There's no mention of oversight. It didn't address the defense put up by the defendants. It doesn't address any efforts to advance or protect public health. So why does all this matter, or why should it matter? Well, first of all, let's look at the moral failures of the physicians in Germany. They were guilty of degradation of professionalism. They gave in to the influence of economic and political pressure. They denied their role as a servant and expediter. Well, actually, they served as a servant and expediter of the goals of the state as regards to suicide, euthanasia, execution, mass sterilization. They became involved in determining the desirability of genetically determined human characteristics. They distorted the role of research versus healer, and they participated in the development of biological weapons. The other failings were the inherent conflict in caring for the health and population as opposed to the individual. They failed in looking at humans as patients and not research subjects, and they did not respond in the face of hostility. All of those moral failures were evident in Germany at that time. So how does it affect us today? Well, first of all, I think we have to be careful that we don't allow medicine to become overly politicized. We need to keep the exam room empty except for the patient and us. The more the government intrudes, the more our independence is going to be pressured. We need to realize, too, that we're under economic pressure as well. We should not be bought. If we do, we're maybe taking the first step down a road we do not want to go into. I think it's inevitable that we're going to have a single-payer system in this country. The simple fact of the matter is that I think we're going to make the same mistakes everybody else did. Whether you like it or not, I think that's what we're going to have. And we're going to have to stand in the way of the government sometimes to protect our patients. How many of you have heard about what's it called, the Physicians Advisory Council? Y'all heard about that? It was debated a lot under Obamacare, and it's come under a lot of criticism. But we're going to have, if you look at it as the population gets older, what's going to happen to healthcare spending? As it is today, it's going to consume a lot of the budget, and we may be faced with decisions about, are we going to put a pacemaker in a 98-year-old? What are we going to do and what are we not going to do? And be wise to think about this before we make those decisions. All right, any questions or comments? All right, thank you.